Before starting the next session, I would like to request the residents to please submit their papers for presentation. The next session is resident free paper contest, and for this session, I would like to invite Dr. S.M. Abbas and Dr. Shamila Athar as the chairperson for this session. Thank you, sir. You may call out the name of the juries for the session.
Bismillahirrahmanirrahim. Now I'm announcing for the most exciting session from the resident point of view, where they will be presenting their topic of research. And first of all, I would like to introduce the jury, Professor Safia Zafar, who is the professor and chair, Civil Hospital Karachi, Department of Anesthesia, Intensive Care Unit and Pain Medicine, Civil Hospital Karachi. Dr. Hamidullah, who is the associate professor and program director of residency program, and Professor Nigat Abbas, who is the senior consultant and former chair, Department of Anesthesia, Liaquat National Hospital. So, with the introduction of this jury, I would like to call first Dr. Abdullah, with the permission of the scientific committee, as Dr. Abdullah is 8th on the list, but he has to catch the flight today. That's why we are calling him first. So the topic of his presentation. So I would like Dr. Abdullah to come. Dr. Abdullah is here? Okay. To come up and... So all the residents, you have 7 minutes for the presentation and 3 minutes will be allowed for the question answer.
So, Assalamu alaikum everyone. My name is Dr. Abdullah, and the study I'm going to present is a cross-sectional survey on skin antisepsis for central neuroexit blockade among anesthesiologists in Karachi. My co-investigators were Dr. Azhar Rahman and Dr. Sarfaz Siddiqui from the Department of Anesthesia as well. Now, the skin antisepsis is of paramount importance when dealing with neuroexit blockades. Microorganisms from patient skin, anesthesiologist, respiratory flora, and colonizing equipment are the major sources of infection during these procedures. Our rationale of the study was to define the current practices for standardization and to assess awareness among anesthesiologists regarding the prevailing practices. The study was exempted by the ERC in May 2021. The study was a cross-sectional survey covering teaching hospitals of Karachi. The survey was conducted within 2 months and the data was collected via online Google Forms. Our population was FCPS faculty. Exclusions were refusal of proceeding for the survey fill-up form and incomplete data forms. Institutional setup, current practices, years of practice along with type of solution used, its application method, and subsequent aseptic practices like sterile gloving, capping, gowning, and masks were also inquired about. Lastly, the consultants were asked about their recommendations for the type of solution used. Statistical analysis was carried out using Ars Studio software. Descriptive analysis was presented as median for the quantitative variables and frequency and percentages for qualitative variables. Associations were determined via stratification. A total of 70 data responses were analyzed out of 78. Majority hailed from the private hospitals, 67%, while half of the population was either associate or assistant professors. The median work of experience was 14 years for them. The type of solution used predominantly was pyridine, which was around 80%. Surgical spirit was barely used by 3% of the anesthesia population. Application method where swab and Gallipod was prevalent at 87%, owing to the fact that pyridine is available in liquid bottle forms. Almost half of the population waited for at least 2 minutes before wiping off the solution of the skin, a method recommended in the guidelines. The recommended solution by the anesthesiologist was, however, chlorhexidine 2%, which was around 52%. And the reason for opting pyridine in their practice was either their personal preferences or the non-availability of the recommended solution. Interestingly, 2% reported burns to chlorhexidine, after which alternate was introduced in their practice. With adherence to the sterility, 98% used face masks in all procedures. Sterile gowns were used in 97% of epidural. However, an excess of major was noted in spinals, where 55% were using a sterile gown for spinal procedures, while 41% was using for caudals. A deficiency was also noted in caudals, with sterile gloving at 95%, drap at 93%, while surgical caps were being worn in only 94% of the cases. In 2014, AAGBI published their practice guidelines, recommended chlorhexidine as a superior choice compared to pyridine in terms of faster onset, longer duration, and more efficacious than being with low incidence of skin reactions. 3/4 of our physicians chose chlorhexidine as a recommended solution. However, the guidelines urge a less concentrated form, which was only the choice of only 22%. Both chlorhexidine and pyridine are cytotoxic, as proven in a study. Hence, in one medical legal case, it was concluded that the injector of spinal anesthesia got contaminated with chlorhexidine. Hence, it is important to have a prudent approach, and the time for the drying is to be given. Capillary action may occur readily if the needle comes in contact with even a small amount of solution, which can be detrimental for the patient, risking chemical acnoditis. Dry time was determined in one study to be 2 minutes for chlorhexidine. In our study, 50% of the population did give 2 minute drying time, while 30% waited for the solution to get dried completely. The spray, however, takes 45 to 60 seconds to dry passively. The study also enumerates chemical burns to chlorhexidine as the reason for discontinuation. It is indeed associated with skin burns, but pyridine too has been reported to cause skin burns during these cases. One common cause among both of them was the pooling of the solution. Hence, the Joint Committee of European and American Society of Regional Anesthesia and Pain Medicine published their advisory recommending use of chlorhexidine over pyridine in PEDS population. Adherence to sterile barriers was over 90%, but the excess use of sterile gown was among half of the population. One study showed no clear advantage using when using sterile gowns during epidurals. It is, however, advisable to consider gowns when placing continuous catheters. Sterile gowns not only put an economic burden but also have a significant environmental impact. It was observed that the senior faculty had an inclination towards pyridine. An argument can be presented with regards to the need for recent updations. Our study, the limitations of our study can be. Yeah. With regards to the strengths and limitations, the limitation of a study can be a relatively small sample size, and the fact that only teaching hospitals were considered. But owing to the metropolitan status of the city, this can be generalized. The strength can be the fact that this study can act as a foundation stone and a reference for future research in the low middle income countries. The knowledge of the local practices were updated by the experts in the field and can help in developing national guidelines. Another limitation was the possibility of a response bias. Hence, there is a need for a national level study which can give us a more holistic view of the overall practice in our country. The recommendation from our study would be that there is limited data from our region regarding the choice and availability of the solution. It's a matter of urgency and importance to raise awareness regarding the safety of neuroaxial blockade procedures. National guidelines are the need of the hour, and further studies on the root cause analysis regarding availability, cost effectiveness, and the incidence and infection or complication of chlorhexidine are needed. Hence, my conclusion would be that pyridine remain an agent of choice among anesthesia faculty members in teaching hospitals across Karachi. The recommended solution still needs to find its way in our practice. Thank you.
Thank you, Abdullah. Were the participants made aware of the guidelines you were using to evaluate them?
No, they were not made aware of the guidelines.
Any more questions? No.
Thank you.
Okay, thank you, Dr. Abdullah. Now I would.
Now I would call on stage Dr. Mehwish Amjad. She is going to present effect of local wound infiltration with ketamine versus dexmedetomidine on post-operative pain relief in terms of quality and duration after cesarean section.
Assalamu alaikum. I'm Dr. Mehwish Amjad, resident anesthesiology, Fizaya Rutfa Medical College. Ladies and gentlemen, distinguished guests, and respected colleagues, thank you for the privilege of addressing 42 annual PSA conference today. I'm honored to stand before you to present comparison of dexmedetomidine and ketamine in local wound infiltration for post-operative pain relief in terms of quality and duration after cesarean section. There was no financial support and no conflict of interest to declare. Post-cesarean pain is an unpleasant feeling resulting from tissue damage signaling the body to the actual injury. Post-operative pain management enhances recovery and decreases morbidity. It is necessary because mothers are expected to take care of their newborns in the earliest hours following the surgery. Ketamine is NMDA receptor antagonist having central and peripheral analgesic property. Dexmedetomidine is alpha-2 receptor agonist having peripheral sedative but no anesthetic character, so it is safe to use as an adjuvant. The aims and objectives of the study is to measure the frequency of pain and duration of analgesia with two different adjuvants, ketamine and dexmedetomidine with bupivacaine in local wound infiltration after cesarean section for post-operative analgesia. The method of the study and the design was randomized controlled trial. The study took place in Department of Anesthesiology, PF Hospital, Faisal. The duration of study was 6 months from July 2023 till December 2023. The sample size was estimated by taking into consideration a previous study by Mohammed et al. The study size was calculated using WHO calculator with confidence interval of 95%, alpha of 5%, and power of 80%. The sample size came out to be 136 patients. For dropout purpose, we took it as 142 with 71 in each group. Sampling technique was double-blind randomization using opaque envelopes. Group A was ketamine group and Group B was dexmedetomidine group. The inclusion criteria was female undergoing cesarean section under spinal anesthesia with ASA status 2 and 3, those who have signed written informed consent. Exclusion criteria was female patient refusal, those patients who have failed or contraindicated spinal needing general anesthesia, neurological or coagulation disorder, those who went into the emergency cesarean section, and those who were unable to understand numerical pain rating score were excluded. Patients meeting the inclusion criteria were allocated into two groups. Randomization was done by anesthesia assistant who was not part of the study using study identification number. The anesthesia assistant opened the sealed opaque envelope, prepared the study drug, labeled it, and gave it to the anesthetist for subcutaneous skin infiltration under all aseptic measures. The study subject and the anesthetist observing patient were blinded to the group assigned. At study entry, the demographic information like age, BMI, ASA scoring, comorbidities, gestational age, and allergies were taken. After explaining risks and benefits, written informed consent was taken from all patients. Numerical pain rating score were explained in detail with 0 as no pain, 1 to 3 as mild, 4 to 6 as moderate, and more than 7 as severe pain. Preoperative investigations were all evaluated. Upon arriving in the operating room, ASA standard monitoring was attached to the patient and baseline values recorded. Under strict aseptic measures, subarachnoid block was administered using bupivacaine 0.75%, 1.5 ml intrathecally. Sensory level was assessed by loss of sensation to spirit swab, and surgery was allowed to proceed after achieving sensory block up to T4 and motor block up to 3 on modified Bromage scale. Patient received subcutaneous skin infiltration of the study drug as an adjuvant to bupivacaine by the anesthetist at the end of surgery after skin closure under all aseptic measures. Group A received 30 ml of 0.25% bupivacaine with ketamine 2 mg per kg as an adjuvant to local anesthetic. Group B received 30 ml of 0.25% bupivacaine with dexmedetomidine 2 microgram per kg as an adjuvant. Postoperative analgesia in terms of duration and quality were assessed for the first rescue analgesia and for total rescue analgesics required in 24 hours on specially designed proforma. Data was analyzed by using Statistical Analysis Program SPSS. Means were calculated for quantitative and frequencies for qualitative variables. Chi-square and t-test were applied for statistical analysis and was found to be significant if p-value was less than 0.05. The demographic data between two groups was not significantly different. The mean time for the first rescue analgesia was prolonged in group B patient. The results showing that significantly different p-values for 6, 12, and 24 hours analgesia in both groups. This result showing the frequency of analgesia needed by 70% of patients in group B is once with a mean of 15 hours analgesia, where 80% patient in group A required analgesia twice or thrice with a mean hour of 8 hours, with a p-value of 0.001, that's significance. In terms of quality, group B dexmedetomidine patients were more satisfied by the ratio of 58% than group A ketamine patient with a ratio of 42%. We concluded that dexmedetomidine was a favorable adjuvant in terms of quality and duration of analgesia for local wound infiltration compared to ketamine in post-caesarean pain management. The clinical implication of the study is that dexmedetomidine is an alternative for local wound infiltration in women undergoing caesarean section to provide analgesia, enhance recovery, and decrease morbidity. There was a study by Mohammed et al. Who used ketamine and dexmedetomidine in local wound infiltration for postoperative pain, and they favored that ketamine was superior to dexmedetomidine in terms of effectiveness, whereas Hefny et al. Favored the results of our study. The limitation of study is single center, female was undergoing caesarean section specifically, and the objective measurement of pain was not done. These are references. Thank you.
Thank you, Dr. Mahvish. Any questions?
Hello. Who made the solution? Bupivacaine with ketamine or bupivacaine with dexmedetomidine?
Ma'am, anesthesia assistant, who was not the part of study, he prepared the solution and then gave it to the anesthetist for infiltration.
Who was infiltrating the drug?
Ma'am, anesthetist. Anesthetist, but he didn't know the drug he was administering.
Okay. It was not being injected by the surgeon?
No, ma'am. It was the study was done after collaboration with the primary surgeon, so they were aware of the procedure.
Okay, thank you.
Were there any systemic effects of either of these drugs noticed in any patients?
Sir, for the sake of secondary outcome, we have calculated the side effects of these drugs. There was no significant, apart from this, that only one patient in group B had hypotension. So that was not as significant either. So that's why I didn't conclude that in result.
Thank you, Dr. Mahvish. Now, I would like to call Dr. Bhavishna Akash from NICVD. She will be presenting comparison of the outcome of short axis out-of-plane ultrasound versus long axis in-plane ultrasound guided radial artery cannulation at a tertiary care hospital, Karachi.
Assalamu alaikum everyone, this is Dr. Bhavishna Akash, and today I am going to present you the comparison of the outcome of short axis out of the plane ultrasound to the long axis in plane ultrasound to guide the radial artery cannulation. So the arterial cannulation is necessary while performing the open heart surgery, such as the CABG, the most common site for it is the radial artery, because not only is it superficial in location, but the hand has the dual blood supply, which leads to the lesser complication rate. The most common site for it is the palpation technique, but this technique can be complicated in patients who are obese, adenomatous, and hypertensive, which leads to the multiple attempts that can cause the hematomas, hemorrhages, and vasospasm. So why not we use some guidance here to make it lesser complicated? Here we are going to use the ultrasound forward needle insertion technique. There are two basic approaches for them in the short axis out of the plane and the long axis in plane technique. So the objective of our study is to compare the outcome of the short axis out of the plane ultrasound versus long axis in plane ultrasound to guide the radial artery cannulation. To achieve this objective, we have calculated some outcomes such as the successful cannulation, cannulation time, ultrasound location time, but we also calculated some modifiers which are going to affect our research, such as the diabetes, hypertension, smoking, dyslipidemia, and the obesity status. The research has been set on the randomized control trial which were performed at the Department of Anesthesia in ICVD for the 6-month duration. We have focused 152 patients which were divided into 76 patients in each group of age 18 to 70 years of either gender. But we have excluded those who were non-consenting, who have the negative modified Allen test, who have the ardent artery occlusion infection at the cannulation site, and the ipsilateral paralysis and the weakness of the upper limb. For the data collection procedure, all the prerequisites were performed, such as the approval from the CPSP and the ethical review committee. The patient were informed about the risk and the benefits, and also the written informed consent was taken. The patient were given randomly opaque sealed envelope during the both group. So in the initial process of cannulation, the standard procedure was performed. The patient were placed in a supine position, the arms were abducted, and the elbows were fixed. The modified Allen test was performed in the non-dominant hand of the all patient. This data was collected by the personnel who have the 1-year experience, individuals supervised by the 5-year experience professionals. And the process of short axis out of the plane diagram. So in the process of short axis out of the plane ultrasound, the mid-probe marker was used to locate the radial artery. Once the location of the radial artery is done on the ultrasound, as it appears with the anechoic circular shadow on the ultrasound, the 1 ml of the 2% xylocaine was injected. After the confirmation of radial artery, after the backflow of the blood, after the confirmation of radial artery, the needle was inserted at the angle of the 30 to 35 degree. And the entry into the artery was confirmed by the backflow of the blood. Once the backflow is confirmed, the core was extracted and the cannula was pushed into the radial artery, then connected to the transducer and the heparinized normal saline strip. Here is a diagram showing the both axes. And in the long axis, the probe was rotated to the 90 degree, and the artery appeared to us as a longitudinal and echoic shadow. Here, after the injection of the 1 ml of the 2% xylocaine, the needle was stapling downward at the angle of 30 to 45 degree. Once the backflow of the blood was confirmed, the needle is then lowered to the 15 degree. And the core was extracted and the cannula was pushed and connected to the transducer, and the following standard procedure was followed. This data was analyzed on the SPSS version 20. The mean and standard deviations were calculated. Frequency and percentage were calculated of the quantitative variables. So here are some results of our study. That the table 1 is showing the comparison between the different variables in the short axis and the long axis. And table 2 is showing the difference between the ultrasound location time and the cannulation time between the short axis and the long axis. It is showing the ultrasound location time of the short axis is only 6 seconds, while in the long axis it is 15 seconds. And the table number 3 is showing the results of the success of the cannulation was higher in the short axis, that is the 68. The table 3 is showing the comparison between the ultrasound location time with the different variables. And the table 4 is showing the cannulation time with the different variables. So the key point of our discussion is the short acting out of the plane and the long acting in plane are widely used in daily practices, but the short axis out of the plane has a lower first pass success rate, that is the only 51%, while the long axis has a 76%. When we switch to the modified short axis out of the technique, we obtain that first pass success rate is the 89%. So technically, the modified short axis out of the plane has an advantage of the long axis in plane, that it takes significantly less time to localize the blood vessels. So it may be a good choice to use the short axis out of the plane ultrasound to locate and to puncture the blood vessel, while we can use the traditional long axis in plane to view the needle insertion. So the conclusion of our study is that modified short axis technique for the radial artery cannulation may significantly improve the rate of cannula insertion success on the first attempt compared to the traditional long axis in plane technique. Here are some references. Thank you.
Thank you, Dr.
Who did
Bhavishna.
the
Any
Ellen's
questions?
test? Who did the Ellen's test in these patients?
The anesthetist,
The one who was performing the radial cannulation.
the one who was performing with the supervisor.
अच्छा, इसमें कोई पेशेंट्स आप लोगों के वो हुए कि जिनका सही नहीं था एलेंस टेस्ट और आपने उनको स्टडी से हटाया?
Yes, some patients who have the either arterial occlusion and they have the positive modified Allen test. In one hand. So we have excluded those.
अच्छा.
But we have performed in both, especially the arterial cannulation is majorly done in the left hand. But we can also use it in the right hand. So we performed actually in the both hands of this patient, and then we concluded this patient on the basis of that.
Okay, thank you.
What is your normal practice in your institution, in plane or out of plane?
What? I'm sorry, I couldn't get you.
आपके institution में normal practice क्या है? आप in plane करते हैं या out of plane करते हैं?
In plane. Out of the plane, sorry. We usually do on the normal basis is the out of the plane technique.
So what was the training of the operator for in-plane ultrasound technique?
What was the training?
जी, जिसने इन प्लेन किया है उसको पहले कितनी ट्रेनिंग मिली थी इन प्लेन करने की?
Yes.
क्योंकि आपकी नॉर्मल प्रैक्टिस आउट ऑफ प्लेन है ना?
Yes. Sir, yes, he was actually trained for that. कि दोनों मतलब उनको आते थे. He was actually trained for that. So our supervisor then trained us for all these planes.
Excuse me, one more question. Doctor, I have one more question. एक सवाल और है, very simple question.
One more question from the audience.
If you have not found the modified Allen's test, आपको समझ नहीं आया, is there any other way to confirm the collateral circulation? क्या करते हैं आप लोग if you don't find that modified Allen's?
Sir, ma'am, we can use the Doppler. We can use the Doppler if the modified negative Allen test is not understanding.
No, the doctor is in. You have to.
Thank you very much, Dr. Bhavishna. Now I would call the next free paper for comparison of intravenous dexmedetomidine and intravenous lidocaine for attenuation of hemodynamic stress response to direct laryngoscopy and endotracheal intubation. Dr. Sidra.
Assalamu alaikum. My name is Dr. Sidra and I am resident anesthesiology from Shaheed Mohatarma Benazir Bhutto Institute of Trauma. My topic of presentation is comparison of intravenous lignocaine and intravenous dexmedetomidine for attenuation of hemodynamic stress response to direct laryngoscopy and endotracheal intubation. Direct laryngoscopy and endotracheal intubation is an important aspect to secure airway in patients require ventilatory support for resuscitation or for general anesthesia. However, it is almost always associated with hemodynamic changes. There are numerous techniques have been incorporated to blunt this laryngoscopic response, including deep level of general anesthesia, beta-blocking agents like asmolol and clabetalol and metoprolol, like IV local anesthetic lignocaine, narcotic agents like fentanyl and alpha-2 agonists like clonidine. But none have proved to be entirely satisfactory. They all have some limitations. So the objective of my study is to compare the outcome of 1 microgram per kg IV dexmedetomidine and 1.5 milligram per kg IV lignocaine in blunting of hemodynamic stress response to direct laryngoscopy and intubation in patients following general anesthesia at Tertiary Care Hospital, Karachi. The study design is randomized controlled trial and the study setting at the Department of Anesthesia Trauma Center, Karachi. The duration of study was from 1st July 2022 to 31st December 2022 and the sampling technique was non-probability consecutive sampling. The sample size was calculated from the parent study using OpenEPI version 3 and 7.8% detect the difference with 95% confidence level and 5% of error. Those patients who were included in this study were who required the general anesthesia for any elective surgery and the patient, the age between 18 to 60 years, either gender, ASA1 and ASA2 patients. The Mallampati classification of those patients were 1 and 2, and the BMI between 18 to 30 kg per meter square. And the exclusion criteria, those patients who were excluded from the study, they didn't give the consent, and the patient with anticipated difficult airway, the pregnant patient as they also have a difficult airway, the patient with a history of uncontrolled hypertension, cardiac, pulmonary, hepatic, cerebral or peripheral vascular diseases, history of sensitivity to either drug used in the study, and those patients who took a prolonged intubation time longer than 15 seconds. And this study was conducted after the approval from ERC and the patient admitted at SMBBIT for the elective surgery under GA. Informed consent was taken from all the patients and all the patients were examined previously for airway assessment, cardiovascular and respiratory system before anesthesia. And data of past surgeries, comorbidities and allergies of either drug was also recorded. All the patients were randomly divided into 2 groups. The group D was dexmedetomidine group and the group L was lignocaine group. And 31 patients were present in each group. Only the anesthesiologists for the specific case were aware of the treatment given. And data collection procedure, the baseline systolic blood pressure was noted, baseline mean arterial pressure and heart rate. It is before the induction, which is labeled as T0. And group D received the dexmedetomidine 1 microgram per kg infusion in 100 ml normal saline over a period of 10 minutes 5 minutes before the induction. And group L received lignocaine 1.5 mg per kg in 10 ml normal saline dilution over the period of 1 minute, and it is given 2 minutes before induction. All the patients were pre-oxygenated by 100% oxygen for 3 minutes. Induction was done by nalbuphine, propofol and atracurium. Laryngoscopy was carried out by experienced anesthesiologists. Tracheal intubation was done by cuffed ETT and anesthesia was maintained by atracurium and isoflurane. Data was analyzed by, and the anesthesiologist recorded the blood pressure, systolic blood pressure and heart rate at first minute and third minute post-intubation. And the finding of quantitative variables and qualitative variables were recorded. This data was analyzed by SPSS version 20. Mean and standard deviations were calculated for qualitative variables with age, ASA status, and hemodynamic parameters. Frequency and percentages were calculated for qualitative variables. An ANOVA test was used to compare the drug used in both groups. Now the results. This is the age distribution group. Mostly the patient were included was between the 20 to 40 years of age. And this is the ASA status. The ASA1 and ASA2, mostly the patient were from ASA1 group, and in both groups, the ASA status was comparable. There was no major difference between these groups. These are the baseline hemodynamics. At baseline, the heart rate was 83 in group D and 81 in group L, and mean MAP was 97 in group D and 95 in group L. Now this is the post-intubation vitals. Post-intubation at first minute, the heart rate was 88 in D group, and in group L was 105, which is very significant, p-value 0.001. And mean arterial pressure was 98 in group D and 108 in group L, with another significant p-value which is less than 0.001. At third minute, it also shows a significant result. The group D shows the less change in heart rate, that is 86 mean, and in group L, it is 98, with significant p-value less than 0.001. And the mean arterial pressure was also significant, 94 in group D and 103 in group L, with significant p-value 0.001. So you can see in this chart the change in heart rate. It is the dexmedetomidine group almost have a straight line. So there is no hemodynamic changes in respect to heart rate. The patient remain the same static heart rate in the dexmedetomidine group. So in this study, there is another study which was conducted by Shrirbman. It found that the laryngoscopy and tracheal intubation increases the arterial pressure and catecholamines level significantly, and it increases the heart rate from 26 to 66%, depending on the method of induction, and systolic blood pressure from 36 to 45%. In another study, the Singh, Van de Berg, and Klindel et al., they said the IV lignocaine 1.5 milligram per kg was ineffective in controlling the acute hemodynamic response following the laryngoscopy and intubation. In another study, it was shown that the lignocaine 1.5 milligram per kg was ineffective in blunting the responses during the laryngoscopy and tracheal intubation. In another study it is conducted, they said they compared the effectiveness of fentanyl and dexmedetomidine in attenuating the stress response to laryngoscopy, and found dexmedetomidine was more effective in preventing increase in heart rate, mean arterial pressure during laryngoscopy and intubation. So the conclusion of my study is, based on the result of the present study, we conclude that IV dexmedetomidine 1 microgram per kg as infusion attenuates the stress response to laryngoscopy and endotracheal intubation more effectively as compared to IV lignocaine 1.5 milligram per kg without any deleterious side effects. These are the references. Any questions?
Were these patients pre-medicated?
Sorry?
Pre-medication मिली थी इनको?
No any pre-medication. Only the dexmedetomidine was given 5 minutes before and lignocaine 2 minutes before induction.
And did you record any hemodynamics after giving the drug and before intubation?
No. Only the after intubation at first minute and at 5 minutes, at third minute. देने से पहले क्या था, एक baseline था at T0 and after intubation, not between the period of drug and intubation.
Did you use midazolam in these patients?
No.
Okay. And what was the analgesia?
Mode of anesthesia, general anesthesia. The patient
analgesia during
analgesia nalbuphine 0.1 mg per kg.
Thank you.
Now, I would call Dr. Nida Akil from Sin Institute of Urology and Transplantation. She will be presenting comparison of dexmedetomidine versus ketofol for moderate sedation in endoscopic retrograde cholangopancreatography, ERCP, a randomized controlled trial. Dr. Nida.
Assalamu alaikum. My name is Dr. Nida. I am from SIUT Hospital, Karachi, and today the topic of my presentation is comparison of dexmedetomidine versus ketofol for moderate sedation in ERCP. The objective of my study is to compare the efficacy of dexmedetomidine. The objective of my study is to compare the efficacy of dexmedetomidine versus ketofol for moderate sedation in patients undergoing ERCP. Conscious sedation is routinely administered during ERCP procedures to enhance patient comfort and facilitate gastroenterologist interventions. However, it is essential to acknowledge that sedation in ERCP carries the potential for adverse intraoperative events. Various pharmacological agents including midazolam, propofol, ketamine, and dexmedetomidine are available, offering rapid induction and smooth recovery. Dexmedetomidine, as we all know, is a relatively recent addition to the pharmacological arsenal. It acts as a potent and highly selective alpha-2 adrenergic receptor agonist, demonstrating sympatholytic, sedative, amnestic, and analgesic properties. Dexmedetomidine stands out for its unique ability to provide conscious sedation and analgesia without inducing respiratory depression. But it can cause bradycardia and hypotension. Ketamine, as we all know, it is an NMDA receptor antagonist, and it also offers sedation, analgesia, amnesia without causing respiratory depression. ERCP procedures are vital for diagnosing and managing biliary and pancreatic disorders, and it has become increasingly prevalent. Recognized as a complex and uncomfortable procedure, ERCP necessitates adequate sedation and analgesia to mitigate agitation and discomfort of the patient. The outcome of my study could contribute to the refinement of management protocols, optimizing the balance between patient comfort and procedural success. In hypothesis, the mean time to achieve adequate sedation and good recovery is better in dexmedetomidine in comparison to ketofol in patients undergoing ERCP. Study design was randomized controlled trial, and study setting was conducted at the Department of Anesthesia, SIUT Hospital, Karachi. Duration of study was from 16th of December 2021 to 15th of June 2022. 62 patients were scheduled for ERCP, 31 patients were included in each group. Sampling technique was non-probability consecutive sampling. I included patients undergoing ERCP, ASA 1 and 2, either genders and ages between 20 and 60 years, and excluded non-consenting patients and patients who were allergic to any of the drug, ASA 3 and 4, BMI over 36 kg per meter square, and patients who had history of stroke, renal impairment, COPD, CLD, and CCF. This is showing how I allocated the patients into two groups, that is DEX group and ketofol group. After getting approval from the College of Physicians and Surgeons and Hospital Ethical Committee, 62 patients were scheduled for elective ERCPs. Informed written consent were taken. A brief history of demographic data was taken from each patient. Preoperatively, assessment was done, history, general physical examination, systemic examination, and routine laboratory investigations were done. Patients were randomly divided into two groups using computer randomization. All patients were taken to the procedure room, and venous access was secured on a dominant hand by a 20-gauge IV cannula. Standard monitors were applied to the patient, which included heart rate, mean arterial BPs, oxygen saturation, and non-invasive BP. Injection midazolam 0.05 mg per kg was also given to the patient to allay the anxiety of the patients. Patients received either dexmedetomidine or ketofol for sedation. All syringes and infusion sets were covered by a silver paper, and these infusions were labeled as infusion 1 or 2. Patient received dexmedetomidine as a bolus over 10 minutes in a dose of 1 microgram per kg, followed by an infusion at the rate of 0.5 microgram per kg per hour, and it was labeled as infusion 1. In infusion 2, we had ketofol. in which bolus dose was given in a dose of 1 mg per kg over 10 minutes, and which was followed by 50 mics per kg per minute of infusion. During infusion, vitals were recorded at 0, 1, 3, and 5 and 10-minute intervals from the start of the procedure, and Ramsay sedation score was recorded every 1 minute. Both infusions were started as per randomization of groups. The mean difference in time to achieve adequate sedation and time to good recovery were noted as outcomes in each group. In addition, complications during the procedure and recovery were also noted. Adequate sedation was defined as the time from initiation or infusion to achieve Ramsay sedation score of 4, while modified Aldred score was used to assess the recovery of the patient, and it was maximum it was 9, labeled as 9 as a good recovery. In statistical analysis, comparison was done to see the association of baseline characteristics, complications during the procedure, and complications during recovery on the outcome. Chi-square test was applied. Moreover, the mean difference of time to achieve Ramsay sedation score and time to achieve Aldred score were explored during using independent t-test. P-value less than or equal to 0.05 was considered as significant. SPSS version 26 was used for purpose of statistical analysis. In results, we had 62 patients. Mean age was 39, and there were 33 males, 29 females. It was observed in 17, and it was ASA status 1 was observed in 17 patients, and ASA 2 was observed in 45 patients. An insignificant association of baseline characteristics was observed in between dexmedetomidine group and ketofol group. The mean time to achieve Ramsay sedation score of 4 was significantly lower in patients who were treated with dexmedetomidine as compared to those who were treated with ketofol. And similarly, mean time to achieve Aldred score of 9 was significantly lower in patients who were treated with dexmedetomidine. This is the table showing baseline characteristics, and there is insignificant association between all these characteristics. And this table is showing time to achieve Ramsay sedation score, which is significant in dexmedetomidine group, and time to achieve Aldred score of 9, which is also significant in group D dexmedetomidine group. These are the complications. No complications were reported during the procedure, except post-op nausea vomiting was insignificantly higher in ketofol group. In discussion, our study demonstrates that dexmedetomidine achieves a significantly faster time to achieve adequate sedation, as indicated by a lower Ramsay sedation score of 4 as compared to ketofol. Similarly, the time to achieve a modified Aldred score of 9, representing a state of good recovery, is significantly shorter in dexmedetomidine group. The current study suggests that dexmedetomidine may offer advantages in terms of faster onset of sedation and shorter recovery times compared to ketofol in patients undergoing ERCP. However, the choice between these sedatives should be made based on a careful consideration of their respective benefits and potential side effects. Hassan et al. Also used these drugs for ERCP in Egyptian population, and statistically there was no significant difference in his study. Despite the strength of this study, including its randomized control design and focus on a specific patient population, certain limitations should be acknowledged. The sample size is relatively small, and the study duration is limited to a specific time. Involvement of relatively healthy adults and effect on older patients with other comorbidities is unknown. The conclusion of my study is that dexmedetomidine is found to be more efficient choice than ketofol for sedation in ERCP procedures, potentially enhancing procedural conditions and patients' comfort. This is a Ramsay sedation score. This is modified Aldred score. These are my references. Thank you.
Any questions?
What is ketofol?
Sir, we combined ketamine and propofol. We used 100 mg of ketamine and 100 mg of propofol, and we diluted that in 20 ml of normal saline and made an infusion, and that we labeled as ketofol.
And how long these ERCP procedures lasted?
Sir, around 30 minutes. 30 minutes. Because I chose ASA 1 and 2, so there was no complication as such as I didn't notice that. So they were done smoothly. I didn't notice any complication.
You monitored the vitals for 10 minutes only.
Sir, that was for my Ramsey sedation score. Ramsey sedation score को मैं like 10 minutes में देखना चाह रही थी ना कि कितना achieve हो रहा है. 4, which was adequate for endoscopic insertion. And
your in the time to achieve your Ramsey score was 11.8 and 13.2 minutes. Is this,
yes.
Is this, you said, is statistically
yes,
significant, but is this clinically significant as well?
Sir, I noticed that. मेरा तो यही ख्याल है सर.
Were these patients as daycare patients or admitted patients? And any patient required admission because of any complication like nausea, vomiting?
ASA1 patients were mostly daycare, and ASA2 patients who had controlled BP and controlled diabetes, they were admitted, but they were in controlled condition, like they were optimized.
So what was the percentage of admission of these patients?
Around that I need to check. I didn't check that, ma'am.
Okay.
We only selected the patients, 62 patients. Thank you, ma'am.
Thank you, Dr. Nida. Now I would call Dr. Sumbul. She will present comparison of intrathecal bupivacaine versus bupivacaine plus dexmedetomidine for post-operative pain relief in terms of quality and duration. Dr. Sumbul.
Assalamu alaikum and good afternoon. Ladies and gentlemen, I am Dr. Sumbul, resident anesthesiology, Fazaya Rutfa Medical College. The topic of my research today is comparison of intrathecal bupivacaine versus bupivacaine plus dexmedetomidine for postoperative pain relief in terms of quality and duration. There was no financial support or sponsorship. There is no conflict of interest to declare. The aim was to evaluate the clinical efficacy of intrathecal hyperbaric bupivacaine with dexmedetomidine versus hyperbaric bupivacaine alone on postoperative pain alleviation in terms of quality and duration in women undergoing cesarean section. Postoperative pain contributes to morbidity. It delays the recovery and return of normal routine. Enhanced recovery of mother improves the neonatal outcome. It increases the mother-child bonding and helps in breastfeeding, early breastfeeding. Dexmedetomidine has recently been studied for its potential to extend the duration and analgesia in peripheral and central nerve blocks. The review of literature shows that there have not been many possible best postoperative analgesics so far. An alternative hypothesis is that there is no difference between the efficacy. The study design was double-blind randomized. The setting was Department of Anesthesiology, PF Hospital, Faisal. The duration was from July to December 2023, and the sampling technique was randomized using sealed opaque envelopes. The sample size was calculated using WHO calculator. The level of significance was 5%, power 80. Anticipated duration of analgesia was considered with dexmedetomidine as 550 minutes and without as 210 minutes. The sample size was 62, considering dropout ratio of 5%. The sample size of 66 was taken. The inclusion criteria was patient's consent, patients undergoing elective cesarean section, and ASA status 2 and 3. The exclusion criteria was failed or contraindicated spinal, the patients who were allergic to any of the drugs, neurological and coagulation disorders, uncontrolled hypertension, diabetes, liver disease, peptic ulcer, high-risk pregnancies, and patients who were unable to understand the numerical rating scale. Demographics were noted, informed consent was taken, and numerical rating score was explained to the patient, where 0 meant no pain and 10 was the worst pain. Patient allocation was kept concealed in sealed opaque envelopes bearing the study identification number. Group A received 1.5 ml of 0.75% hyperbaric bupivacaine plus 5 mites dexmedetomidine. Group B received 1.5 ml of 0.75% hyperbaric bupivacaine alone. In both groups, preloading with lactated ringer was done, vital monitoring was done, and oxygen was supplied via face mask. Sensory level was assessed by loss of sensation by Swear swab and pain by pinprick method. Surgery was allowed to proceed after confirming the sensory block to the level of T4 and motor block by Bromage 1. Postoperative pain scores and analgesia duration were documented at following hours and whenever the patient complained of pain and rescue analgesia was given. The analysis was done via SPSS version 26. The qualitative variables, frequency and adverse effects, chi-square was used, and for quantitative variables, the mean and standard deviation t-test was used. P-value of less than 0.05 was held statistical. The primary outcomes were quality of pain relief using NRS, the number of times the rescue analgesia was required, and the total dose of rescue analgesia in 24 hours. The secondary outcomes were the time when the first rescue analgesia was given and side effects. As shown, the demographic variables were statistically not significant. P-value at 3, 6, and 12 hours is significant. 21% of Group A patients complained of moderate pain, whereas 78% of patients in Group B complained of moderate pain. This is the time of rescue analgesia. So 51% of patients required rescue analgesia twice in Group A, whereas 60% patients required rescue analgesia 4 times in Group B. And if we see the mean rescue analgesia, it is almost double in Group B. Mean first rescue analgesia, as shown, is at 14 hours in Group A and 3 hours in Group B. Among side effects, only shivering held statistical implication. The conclusion was intrathecal dexmedetomidine can improve pain in terms of quality and duration when used as an adjuvant with local anesthetic bupivacaine in cesarean section patients. This is a small comparison. The study of Mover et al. Showed that the first rescue analgesia is prolonged with dexmedetomidine. Our study showed 14 hours and his study showed 12 hours. Nasser et al. Showed that the faster and prolonged sensory block, stable maternal hemodynamics, and low incidence of postoperative shivering after dexmedetomidine use. This is the clinical impact. The use of dexmedetomidine prolongs the hour before requirement of first rescue analgesia. It decreases the 24-hour rescue analgesia requirement to almost half and lowers the incidence of shivering. The limitation of my study was that it was gender-specific, group-specific, single-centric, and the pain management score was subjective. These are some of the references. Thank you.
What is the volume of drug you injected in intrathecal space?
Ma'am, 1.5 ml of bupivacaine and 5 mites of dexmed.
5 mics means how much in mLs?
Ma'am, it was 0.01 ml.
I think it is very difficult to calculate 0.01 ml.
Ma'am, we get Precedex in our institute. It is 2 ml and 100 mites. So it was 0.01 ml which was introduced in the patients. Sir.
Okay. और फिर पेन असेसमेंट किसने किया?
Ma'am, anesthetist who was on duty.
Okay, the same person नहीं था जिसने इंजेक्ट किया था?
No, not the same person.
Okay.
Isn't it obvious that 2 drugs would have a better effect than 1?
Yes, sir, I would say so.
साइड इफेक्ट्स किस ग्रुप में ज़्यादा हुए हैं?
साइड इफ़ेक्ट्स ओवरऑल इतने ज़्यादा नहीं हुए, सिर्फ शिवरिंग कम हुई उन पेशेंट्स में इन विच वी यूज डेक्समेथासोन.
अच्छा, चलिए, थैंक यू.
थैंक यू.
Now I would call upon Dr. Sadia Sohail from Hamdard University Hospital. She will be presenting Burnout, a rising alert among resident anesthesiologists and consultant anesthesiologists.
Assalamu alaikum. I'm Dr. Sadia Sohail. I'm resident anesthesiology at Hamdard University Hospital. Thank you for giving me the opportunity to present my paper over here. I'm going to present on Burnout, a rising alert among resident anesthesiologists and consultant anesthesiologists. Well, according to Cynthia de las Fontes, burnout can cause loss of contact with self and one's need, leading to ravaging oneself. So burnout is actually a state of emotional, physical, and mental exhaustion caused by excessive and prolonged stress. It occurs when you feel overwhelmed, emotionally drained, and unable to meet the constant demands. According to WHO, burnout is a syndrome conceptualized as resulting from chronic workplace stress that has not been successfully managed. Signs and symptoms may include reduced productivity, anxiety, detachment, feeling listless, low mood, difficulty concentrating, lack of creativity, and fatigue. It can further lead to personal and professional dissatisfaction, social isolation, relationship problems, depression, substance abuse, and in extreme cases, suicide. Physical symptoms may include shortness of breath or even persistent chest pain, may feel heart palpitation, dizziness, heartaches, headaches, and stomach problems. Also as diarrhea as well. ICD-11 defined burnout as a syndrome resulting from chronic workplace stress that hasn't been successfully managed and in the absence of any sort of adjustment disorders, stress-related disorders, and anxiety. Stress and burnout are common among anesthesiologists due to the nature of their high-stress jobs. Long work hours may interfere personal lives, leading to burnout. So our study aims to assess and compare the prevalence of burnout between resident anesthesiologists and consultant anesthesiologists in relation to work by using Maslach Burnout Inventory Scale. So it was a cross-sectional study performed by Hamdard University Hospital Department of Anesthesia after acquiring ethical permission from the board. It's a multi-center study and the duration was of 6 months. So after thorough research review and using 95% confidence interval, we sent 160 questionnaire to the anesthesiologist, and we designed the questionnaire after a thorough literature review. The first part contained, the form of the first part contained basically the consent form. The second part contains socio-demographic status. The third part contains clinical history. The fourth part consists of MBI scale, HSS, that is Human Services Survey. MP is for medical practitioner, using 7-point Likert scale. Questionnaire was sent via email. After 3 soft reminders, only 69 responded. 11 were excluded due to incomplete filling of the questionnaire. Only 58 responders were selected for the study, and the response rate was 67.4%. So inclusion criteria was all the resident anesthesiologists, all the consultant anesthesiologists who were posted in OT rotations, and those who gave consent. Second, we excluded all those resident and consultant who were in CCU rotations or on ICU rotation. Socioeconomic status, incomplete filling of the questionnaire, physician assistants or nurse practitioners were excluded. So the data was entered in the SPS 26 version to perform the analysis. Yeah, Maslach burnout inventory. It's a psychological assessment instrument comprising of 22 symptom items pertaining to occupational burnout. To assess the individual experience of burnout, the instrument takes 10 minutes to complete. The MBI measures on 3 dimensions, on emotional exhaustion, depersonalization, and personal accomplishment. So MBI HSS is a 22 items and it's original and most widely used version of the MBI among doctors. And the difference is basically instead of patient, it uses recipients. It's 73.5% sensitive and 97.8% is specific according to Maslach itself. So emotional exhaustion part consists of 9 questions. Those who score greater than 27, they will considered as high. Moderate is between 17 to 26 and low from 0 to 16. Next cardinal feature is depersonalization, which has 5 questions. The score, if it's greater than 13, then it's high. From 7 to 12, it's moderate. And from 0 to 6, it's low. Personal accomplishment consists of 8 questions. Same, if the score is greater than 39, then it's high. Moderate if it's between 32 to 38. And low if it's less than 31. According to the MBI scale criteria for burnout, we have to calculate if it's high emotional exhaustion or high depersonalization, or high emotional exhaustion or low personal accomplishment. Results. So 67.4% was the response rate. 70.69 resident anesthesiologists responded to the question. Among them, 50% met the criteria of burnout. 29% of consultant anesthesiologists responded to the questionnaire. Among them, only 8.6 met the criteria of burnout, which is a huge difference. No significant difference was seen on basis of gender. So these are the demographics of the respondents. The resident anesthesiologists who responded were 70.69 and the consultant were 29. It's demographics of male and females, the age related, and these are the basically resident anesthesiologists responding to MBI HSS MP. So what you have seen is in emotional exhaustion, 50% responded that they are emotionally exhausted. Only 36.20% responded that they feel depersonalization. And low personal accomplishment was seen in 24.13% residents. In consultant anesthesiologists, only 8.6% emotional exhaustion was seen. 6.89% in depersonalization, while 8.6% in personal accomplishment. In a recent Pakistani study, the prevalence of burnout among anesthesiologists is 22.05%. According to a study done by ASA, American Society of Anesthesiologists in United States, 13.6% responded to their survey, and among them 13.8% met criteria of burnout. So basically the future impact of our study was to promote mindful-based programs to focus on eradication of factors causing burnout. Limitation, our sample size was very small. The study did not include factors which were leading to the burnout. The study did not focus on how to prevent burnout. So in conclusion, this study demonstrated that burnout is more prevalent in resident anesthesiologists than consultant anesthesiologists. However, factors causing burnout and its preventive measure needed to be addressed to overcome burnout among anesthesiologists. Thank you. Any questions?
This scale, as I remember, measures the last 3 months of their performance leading to their burnout. Is that correct? Did you look at the level of residents who were in their career closer to exams or away from exams?
No, we didn't focus on the factors which were causing burnout.
Thank you.
Thank you.
The next speaker is Dr. Sehrish Khan. She will present evaluation of hemodynamic response to laryngoscopy and endotracheal intubation, conventional laryngoscope versus CMAC video laryngoscope in patients undergoing elective coronary artery bypass grafting surgery, a randomized controlled trial.
Assalamu alaikum everyone. I am Dr. Serish and I am here to present my topic titled as Evaluation of Hemodynamic Response to Laryngoscopy and Endotracheal Intubation using Conventional Laryngoscope versus CMAC Video Laryngoscope in the patients undergoing elective coronary artery bypass grafting surgery. It was a randomized controlled trial. The background of our study was that the patients undergoing coronary artery bypass grafting surgery, they have often limited cardiac reserves. Hemodynamic perturbations induced by airway manipulation can precipitate myocardial supply and demand imbalance. Video laryngoscopes has gained popularity due to its potential to exert less mechanical force during laryngeal alignment, resulting in reduced stress response and improved hemodynamics. With this, we come up with the rationale that cardiac patients have limited cardiac reserves, so wide variations in hemodynamic parameters during induction of anesthesia might be devastating. Use of CMAC is thought to reduce these wide variations. The hypothesis of our study was that a CMAC video laryngoscope would provide better intubating conditions along with the stable hemodynamic parameters, improving outcome by reducing morbidity in patients with little cardiac reserves. The objective of our study was to compare the hemodynamic response between conventional laryngoscopy using the Macintosh blade and CMAC video laryngoscope during endotracheal intubation in patients undergoing elective CABG. Primary outcome was to assess the hemodynamic response, and the secondary outcome was to assess the presence of arrhythmias and perioperative MI. The methodology we used for our study was that it was an randomized controlled trial in the patients who were planned for elective CABG. The study was conducted in AKUH cardiac wards for a period of 12 months, and the sampling technique we used for our study was a non-probability consecutive technique. The patients who were age of 35 to 65 planned for elective CABG with ASA physical status of 3 and 4 having unanticipated difficult airway were included for the study, while those who had BMI more than 35, thyromental distance of less than 6 centimeter, undergoing emergency procedure, recent history of MI, neurological deficit, and with bleeding diastasis were excluded from it. Patients were pre-medicated with 7.5 mg oral midazolam prior to anesthesia. Standard monitoring applied. Arterial line and whiteboard IV cannulation were performed before induction of anesthesia. Anesthesia technique was standardized in both groups. All the intubations were performed by anesthetists having more than 2 years of experience or who had done intubations more than 20 or equal to 20 with video laryngoscope. Different parameters were recorded at different time points. T1, the baseline, T2 after induction, T3, T4, T5, 1 minute, 5 minutes, and 10 minutes post-intubation respectively. Failure to intubate was defined as the inability to intubate after 3 attempts. This is the consort diagram. As you can all see that 89 patients were assessed eligible for the study. 3 patients were excluded from the study as they did not give the consent. Remaining 86 patients were allocated to 2 arms of the study. Each contained 43 patients. There was no loss to follow patient, so all the patients were analyzed where they were randomized. Statistical analysis was done with using RStudio. For the descriptive analysis, for the quantitative variables, mean and standard deviation were computed. For the qualitative variables, frequency and percentage were computed. In the inferential analysis, independent t-test was used for the quantitative variables, while chi-square or Fisher exact test was used for the qualitative variables. This is the comparative analysis of Macintosh group and video laryngoscope group. This is quite comparable in both the groups. We have used these error bar charts to show the hemodynamic parameters variability, that is mean heart rate variability, mean systolic blood pressure variability. There was no significant variation across these 2 laryngoscope groups. However, at T2, the mean heart rate was slightly lower in the patients who were intubated using video laryngoscope groups. This is the hemodynamic parameters variability, mean diastolic blood pressure and mean arterial blood pressure variability. That was no statistically significant variability across both groups. These are the intubation related parameters. As you can see that external pressure required for intubation were slightly lower in patients who were intubated with video laryngoscope groups. However, the duration of intubation is slightly prolonged in patients who were intubated using a video laryngoscope blade. Now, with the discussion, our study contributes to the existing body of literature that examines various airway devices and their impact on hemodynamic response during intubation. Our study by Malik et al. Showed that airway scope caused less hemodynamic stimulation than the other laryngoscopes. It produced minimal variation in heart rate during intubation attempts. This supports the notion that specific devices can influence the cardiovascular response. Another study highlights the potential of stylet scope in mitigating adverse hemodynamic response during intubation. The study by Kanchi et al., which demonstrated no significant variations in hemodynamic responses across different laryngoscopic groups, aligns with the point of similarity with our findings. The findings of our study and the reference studies collectively emphasize that while variations in airway devices might impact hemodynamic responses, the differences might not always be clinically significant. As anesthesiologists, these insights guide us to holistically approach airway management, keeping in mind that a balance between choosing the right device, patient condition, and physiological impact leads to effective airway control with minimal disruption. There are a few limitations of our study that large sample size might affect the results. Preoperative antihypertensive drugs may also produce significant variability between the groups. Autonomic instability due to diabetes can also be a reason. With this, we conclude our study that the hemodynamic responses observed were comparable in both groups and with no discernible advantage in terms of obtention of cardiovascular response to laryngoscopy and endotracheal intubation. However, further studies are still required to establish the efficacy and safety in difficult airway scenarios. There are some references. Thank you so much.
आपके पेशेंट एज से 3 और 4 थे तो दे मस्ट बी ऑन एंटी हाइपरटेंसिव ड्रग्स.
यस मैम.
तो उसमें कोई रिलेशन था कि कौन सी ड्रग्स लेते थे या सब एक ही लेते थे? वो तो नहीं लेते होंगे.
सब एक ही नहीं लेते थे. देयर वर कम्बिनेशन ऑफ ड्रग्स, बट ये हमारी लिमिटेशन में मैंने इसको इसीलिए एक्सप्लेन किया. स्टिल कंट्रोल्ड हाइपरटेंसिव पेशेंट्स थे वो, बट ऑन मल्टीपल ड्रग्स.
Okay, thank you.
Thank you so much.
Okay, next I would call upon Dr. Mohammad Farhan from Indus Hospital, who will be presenting to assess aseptic techniques used in labor epidurals practiced by anesthesiologists among various teaching hospitals of Karachi. Dr. Farhan.
Assalamu alaikum. A very good afternoon to all of you. My name is Dr. Farhan Hassan and I am Year 4 resident in the Indus Hospital, Karachi. Today's the topic of my paper presentation is a survey of aseptic techniques for labor epidurals by the anesthesiologist in tertiary care hospitals of Karachi. So as you all know that epidural analgesia is a particularly common treatment for labor pain, and aseptic technique and hand washing have been shown to be the important element in inhibiting the bacterial transmission. Asepsis is perilous to the performance of epidural anesthesia in the prevention of contamination and concomitant complications. The objective of my study was to assess the aseptic techniques used in labor epidural practiced by anesthesiologists among the various teaching hospitals of Karachi. The rationale of my study was as there is limited data in Pakistan regarding the aseptic technique for labor epidurals, and there are differences among the different institutes and the different physicians which are practicing the labor epidurals. So therefore, we want to find out which components of aseptic precautions are considered essential by the physicians. In the methodology, the study design was cross-sectional study. The setting was teaching hospitals of Karachi, and the duration of my study was 6 months. In the sample selection, the inclusion criteria consists of the anesthesia consultants, the specialists, the residents, those who are working in the tertiary care hospital, and they were of either gender, and all those who participate and give the consent. The exclusion criteria consists of all those residents who are working in the secondary care and primary care hospitals, and those who refuse to give the consent. The sample size was calculated by using OpenAPI software. Approximately 145 anesthesiologists were recruited. The study was conducted after the approval of IRB of the Indus Hospital and the CPSP. Practicing anesthesiologists were contacted from different tertiary hospitals. Individual who were fitting in inclusion criteria was contacted by the principal investigator and then explained the purpose of the research survey. After that, a verbal consent was obtained before giving the online questionnaire. The data was analyzed using SPSS version 26. Quantitative variables such as age, years of experience, duration of working independently, number of epidural performed in the month, and number of epidural performed in a center yearly was assessed for the normality. So these are some results. The mean age of my participants were 33-year-old, and the duration of work they were working independently in their hospitals were 4 years. The labor epidural they perform or supervise in a month was 8, and the epidurals performed in their centers were 200 per year. This is the gender distribution. 50% were the residents, 35% were specialists, and rest were the consultants. 73% were from the private setups, and the remaining were from the government setups. So I have concluded some results that showed the significance on my study. So the questions were asked to the participant that how did they wash their hands before performing the labor epidural. So when they were asked about the with pyridine, when they used the pyridine up to the elbow and pad dry with the sterile towel. So private in the 79.2% of participants from private institutes said that they used this method, and 8.5% that did not extend it up to the elbows. 12.3% use HexiPrep. While you can see in the government setup, 64% use up to the extended up to the elbow, 18% approximately used did not extend up to the elbow, and 18% also use HexiPrep. Then another question that shows significant impact on my study, that how do you practice the epidural? So whether they remove jewelries or rings or watches or bracelets before using the performing the epidural. So 84.6% of my government setups candidates participants say that they remove it, while 90% of participants said from the private institute they said they remove it. And you can see that 15.4% from government setups say they doesn't remove anything, and 9.4% from private setup they say they doesn't remove anything. Another question was whether they wear a sterilized gown and gloves. So from government setup, no one responded to the only sterile gown option. 28.2% say that they wear only sterile gloves while placing epidural. 71.8% say they wear both of them. And in private setup, you can see that 1.9% wear only sterile gown, 6.6% wear only sterile gloves, and 90.6% wear both of them. Another question was that whether they wear a surgical hat or face mask. So 5.1% from government setup say that they wear a surgical hat, 10.3% say they wear only face mask, and 82.1% say that they wear both of them. And you can see in private setups that 2.8% say that surgical hat they wear, 10.4% say that they wear face mask, and 86.8% say that they wear both of them. But you can see that 2.6% of the government participants also say that they wear none of them. Then they were asked that which antiseptic solution they use. So in government setup, 41.7% say that they use HexiPrep while creating a sterile field, and 58.3% say they use pyridine. And in private setup, 26.3% uses HexiPrep, and 73.7% use pyridine. And to secure and maintain the cleanliness at the insertion site, what did they use? So in the government setup, you can see that 36.1% uses sterile fixation device, 38.9% use offsite, 19.4% use sterile gauze with adhesive tapes, and 5.6% use adhesive tapes only. While in private setup, you can see that 27% use sterile fixation device, 60.4% use sterile offsite device, and 11.5% use sterile gauze with adhesive tapes, and only 1% use adhesive tapes. So the results suggest that the practice of aseptic techniques for labor epidural insertion currently varies among all the physicians across the city. Evidence-based guidelines are necessary for all steps of epidural catheterization, starting from the preparation to the procedure itself. This will ensure that more rigid aseptic technique in order to better protect the obstetric population from infectious complications. So these were my references, and that concludes my presentation. Thank you.
Do you have any data on the infection rates of these institutions for related to epidurals?
Rate of infection?
Infection rate in these hospitals related to epidural insertion?
No, just we assess the aseptic techniques that were practicing by the anesthesiologist.
And all your data is comparing the private sector and public sector.
I earlier said that I included only those results that give the significant impact on my study. I compare on the basis of gender. I compare on the basis of age group. I compare on the basis of that senior and junior also. But this was as you know that we have limited resources in government setups, and we have some better resources in private setups. So this causes the impact on my study.
But there was no difference among the juniors and seniors and faculty?
According to the p-value, there was no significant.
And your most interesting group was the people who wear a gown but don't wear gloves.
Yeah. Yeah. They opted that. Thank you.
The next topic is behavior and perception of healthcare providers regarding newly developed new pain score for pain assessment. The presenter is Dr. Bushra Jamali.
Assalamu alaikum everyone. Dr. Bushra Jamali, resident year 3 in Dr. Ziauddin Hospital, Karachi. Today my topic that I'm presenting here is behavior and perception of healthcare providers regarding a newly developed pain score for the assessment of pain. Visual analog scale and numerical rating scale are preferred for pain assessment due to their simplicity, ease of use, reliability, and validity worldwide. Understanding of these scales can vary based upon the factors like age, literacy, and ethnic origin. The cultural affects the expression of pain, so cultural appropriate assessment tools are very crucial for effective pain management. Our rationale in this study was a reference study that we took was they developed a new pain scale in 2 phases. They initially selected a culturally appropriate pain assessment scales by involving their healthcare providers and patients, and they tested those pain scales on the post-op adult patients. This study forms the basis of our research. We assessed healthcare workers' perception regarding our new pain scale, and in the next phase, we are planning to implement this pain scale on the patients. We aimed to introduce the new pain scale, which we called as descriptive pain score, derived from already validated scales like VRS, that's a verbal rating scale, and numerical rating scale. We integrated Urdu for the better understanding. Our objective was to assess the behavior and perception of healthcare providers regarding new pain scale as compared to visual analog scale and numerical rating scale. The methodology that we implement, we did a cross-sectional study after approval from ERC at Department of Anesthesiology, Dr. Ziauddin Hospital, Clifton Campus, Karachi. We used non-probability convenience sampling and included the healthcare providers, including doctors, nurses, and paramedic staffs with at least 6 years of clinical experience. We distributed self-structured questionnaires to nurses, doctors, and paramedics. Out of 50 questionnaires distributed, 40 were responded. The data was analyzed using SPSS version 24. Age was represented in mean plus minus standard deviation, while the gender, designation, level of education, and working experience were represented by frequencies and percentages. The behavior and perception compared with designation, level of education, and working experience by using chi-squared or Fisher-Exact test. The p-value of 0.05 was considered statistically significant. The data of 40 healthcare providers was analyzed. The mean age came out to be 32 plus minus 9.8 years, ranging from 23 years to 77 years. The gender distribution was 55% were males and 45% were females. The behavior was compared by the designation, education, and work experience of healthcare providers, and the statistically significant difference was found in NRSAs by education level. That p-value came out to be 0.030. We can see in the results that the postgraduates found numerical rating scale easiest to implement, followed by 22% of bachelors and 17% of diploma holders. The second aspect of our study was the perception, which was compared by role, designation, education, and work experience. It came out that pain score perception differs by experience, in which the p-value came out to be 0.001. Now here the interesting fact was the DPS, or the new pain scale that we used. The positive opinion regarding that was that those healthcare providers who had 1 to 3 years of work experience, they responded 40%. They found 40% of those who had 1 to 3 years of working experience found it easy. The 41% of healthcare providers who had 6 to 10 years of working experience found regular NRS, and those who had 4 to 5 years of working experience found VAS easy to implement. You can see in this graph, the healthcare providers who had 1 to 3 years of experience found DPS, or a new pain scale, easy, while the most who had 4 to 5 years of experience found NRS and VAS. During the development of our pain scale, we conducted a survey in which we involved our healthcare providers, including doctors, to validate this tool. To ensure the cultural appropriateness, we incorporated Urdu language for the clarity and understanding. While the reference study that we used, they only involved 25 clinical nurses in the development process of their own scale by doing interviews and focus group discussions. However, they highlighted their cultural significance in the forms of colors in their pain assessment score. The limitation of my study is as this was our pilot study, we used convenience sampling and the sample size was small, so it limits its generalized application. We recommend more larger and more diverse studies across various healthcare settings to validate it more. Our conclusion was the postgraduates found implementing NRS easiest. However, positive opinion regarding our pain score, which is called as descriptive pain score, was obtained by 40% who had 1 to 3 years of working experience. These are the references of my study. Thank you.
The doctors included in your study, was all of them are anesthetist or any doctor, MO?
We included all the doctors, not only anesthesiologists, including residents from surgery, gynecological department, urological, medicine department. We tried to just generalize this as more as we can.
Okay, and the matric and inter pass, they are paramedics mostly.
Sorry ma'am, I can't hear you.
आपके डेटा में कुछ तो मैट्रिक और इंटर पास भी लिखा मैंने देखा. सारे डॉक्टर्स थे क्या?
No ma'am, the doctors were there. Also they were paramedics. They had education level starting from matriculation to intermediate to diplomas as well.
Okay, thank you.
Thank you.
So what is the way forward now with you?
Sorry sir?
What are you going to do next?
So we are trying to implement this on our patients to see what response we can get from them.
But with this level of acceptance of 40%, you think this is going to go forward?
Sir, we have tried this in the outpatient department, so we have seen a good response from them. Okay, thank you so much.
Thank you very much. And with this presentation, I would conclude this session. I'm sure that everybody has become adequately dexmedetomidinized. Almost 40% research papers were on dexmedetomidine.
The poster contest is still going on, so we will wait for another 15 minutes. In the meanwhile, you can compile the results, and in the meanwhile, we can also do the certificate distribution for the chairs and the free paper presenters. Can I please request Dr. Jawdat Salim to come on stage and present the certificates to the chairpersons of the free paper? participants को मुझे.
So please, Professor Nigat Abbas to the jury for the certificate. Acha ji. Okay. And Dr. Shamila Athar as a chairperson. And Dr. S.M. Abbas as a chairperson. So I would like to request Dr. Naveed Masood to be on stage to present the certificates to the participants and the jury members. Dr. Bhavishna Akash. Dr. Mehvish Amjad. Dr. Bushra Jamali. Dr. Farhan Hassan. Dr. Sehrish Khan. Dr. Sadia Sohail. Dr. Sumbul, please line up. Dr. Nida Akil. Dr. Sidra. And Dr. Abdullah. Dr. Sadia. Dr. Sumbul, please. Dr. Nida Akil. May I request that Dr. Abdullah? Right. May I request the jury to be here on stage for the certificate distribution, please? Professor Safia Zafar. Dr. Hamidullah. Professor Nighat Abbas. One of our participants is left. Dr. Sidra, please.